Hello, my name is Jeff Paurus. I'm a nurse and a nursing instructor from the US, and I've had the pleasure of being a volunteer in India for a number of years now. So I'll be giving one of the talks today, and this is recorded. Sorry, it's not live, but it's recorded. But my talk today is Principles of Preoperative and Postoperative Care. Okay. Before surgery, one of the key principles really, and one of the key principles that motivates us to give good preoperative care and make sure the child's ready and provide the most support possible is that the healthier and the more prepared a child is before surgery or before a surgical heart cath lab procedure, the greater the likelihood of survival and the more likelihood of a positive surgical recovery, surgical outcome and recovery. So greater likelihood of survival and the greater likelihood that the recovery will be smooth and progress rapidly and be successful. So everything we can do to get the child prepared and in best condition, preoperative, will make a difference. So talking about the RBSK nurse's role, if it's emergency surgery, we don't really have time to prepare. This child has to be taken in, or the newborn has to be taken in for emergency surgery, emergency procedure, and we don't have much time to prepare. But most of the time, there is some time for us to prepare and for the RBSK nurse to make visits or phone calls and to help prepare the child and actually the family too for the upcoming surgery. So most of the time in most cases, we do have some time to optimize the child's condition before they're sent to surgery and before they have to face the challenges of surviving and recovering from surgery. So also another thing that the RBSK nurse can do is assess what resources are available, or what resources are needed by the child and by the family in preparation for the surgery, and anticipate what will be the needs after surgery, what will be the needs at home after surgery as the child recovers at home. So that gives us a chance to prepare before surgery and to make some planning for the postoperative period too. And I'll talk about a couple different areas. One is respiratory. And if we have the time, and if we can do this, 2 weeks before surgery, the child should be isolated from any persons with colds or other respiratory symptoms. So you want to really protect the child from people that might be contagious with something that's going to affect their pulmonary status, their lung status. So most commonly it would be colds. And one of the problems with that, one of the problems of being exposed to a cold and the child developing a cold is that the risk of a perioperative respiratory complication, a problem during surgery or after surgery, is increased by 2 to 10 times. So much more likely to have a respiratory problem during surgery or after surgery if that child's been exposed to someone with a cold and if they develop cold symptoms immediately before surgery. And some of the complications be lung infection, pneumonia, or other type of lung infections. And one of the dramatic complications that could happen is more likely to happen if the child has a cold when they're going to surgery is laryngeal spasm or a spasm of the larynx. And you can see in this picture, here's children with cold symptoms, runny nose, cough, but now here's the larynx, which is normally opens and closes. But laryngeal spasm is when that airway closes and it's in spasm and it's nearly impossible to breathe and it can be life-threatening. So that's a problem that we want to avoid if at all possible. And if we can keep the child safe from colds or respiratory infections before their surgery, it's going to be much, much less likely that they'll develop these complications. Talking about further respiratory issues, the RBSK nurse should assess if the child has frequent colds. With the visits, we can see if the child has frequent colds, if we need to take special respiratory precautions, if that's going to be something that we can anticipate. Does a child have asthma? How well controlled is asthma? Do they have frequent acute asthmatic episodes or asthmatic attacks? What medications are they using now to control their asthma, to treat their asthma? And how often do they have to use those medications? And another factor, looking here with this poor girl here, surrounded by 7 cigarettes here. Do adults smoke in the house? Are they routinely exposed, is the child routinely exposed to secondhand smoke? And that's something that we can do a lot of teaching. We can do a lot of teaching and say, you want to make conditions as good as possible for your child to do well in surgery and recovery. And if people are smoking in the house, that's secondhand smoke, what we call secondhand smoke, can really affect the child's lung condition and affect their likelihood of having a smooth surgical recovery or a problematic surgical recovery. So evaluate the presence of secondhand smoke. Nutrition is a key for a lot of recovery, a lot of the readiness for a child for surgery and their recovery for surgery and the potential for complications after surgery. So deficiencies, any kind of deficiencies, including vitamin deficiencies, overall calorie deficiencies, protein deficiencies, can all make a child at more risk for complications in the surgery, during the immediate recovery, and for the long-term recovery. So we'd like a child to be as well-nourished as possible, to be adequate weight, to have be free of vitamin deficiencies, to be in good condition with that. And so here's a chart with vitamin deficiencies. Vitamin A, what vitamin A affects, the B vitamins, multiple B vitamins, vitamin E deficiency, vitamin C, vitamin D. Vitamin C deficiency can slow down wound healing, can interfere with wound healing. Vitamin C deficiency can also increase the risk of bleeding. Vitamin D can have problems with bones, rickets, seizures, respiratory problems. So really all these vitamins A, the fat soluble vitamins A, D, E, and this graph doesn't mention vitamins K, I will in a little bit, and then water soluble vitamins, the B vitamins and vitamin C. So any vitamin deficiency has a potential of making surgery more difficult, recovery from surgery more difficult, survival in surgery somewhat more difficult too. Often children with congenital heart defects start out with low birth weight, and often they have feeding problems. So often they're kind of set up to be more likely to be undernourished or malnourished. The risk is greater. So we want to try to address that in the preoperative preparation of these children. And one study from Thailand found that about 40% of children with congenital heart disease had malnutrition. So almost half, about 40% children had some degree of malnutrition. So that makes them at a high risk. So we want to do everything we can to mitigate, help lessen that risk with nutrition. Here, possible more specific effects of nutritional deficiencies. Some examples include vitamin C and vitamin K deficiencies can increase the risk of excessive bleeding. If a child's deficient with vitamin K often comes with green leafy vegetables as a source, but if they're deficient with vitamin K or deficient of vitamin C, that increases risk of excessive bleeding in surgery and after surgery. So it makes bleeding and blood volume, maybe blood replacement, more needed, and the risk of anemia and complications afterwards more likely. And we all know that it's the hemoglobin in the blood that does the most oxygen carrying. So if the child's anemic, if they have a low hemoglobin level, it's going to be difficult to adequately oxygenate the rest of the body's tissues. Regardless of how well their oxygenation saturation is, if their hemoglobin is low, they won't be able to deliver oxygen. Their oxygen delivery to the tissues of the body is going to be less, regardless of how well saturated the hemoglobin molecule is. So increase the risk of excessive bleeding, vitamin C and K deficiencies. Protein deficiency can decrease the effectiveness of the immune response. It also decreases antibody formation, can interfere with antibody formation. So the immune response will be less effective. Low albumin levels. Albumin is a major plasma protein. Low albumin levels can cause actions of medications to be more unpredictable. Some medications are bound, connected with the plasma, with the albumin. They're connected, bound with plasma albumin. If plasma albumin is low, there'll be more free medication. If plasma albumin is high, there'll be less free pharmacologically active medication. So plasma levels, low plasma albumin levels can make medication action more unpredictable, more of a management challenge in the ICU and the post-op recovery. And overall, nutritional deficiencies, caloric deficiencies, lack of calories, but also protein deficiencies can cause delayed healing and delayed recovery for the child. So the best case that can be, again, the best nutritional status is we can promote before they go to surgery, the greater likelihood there'll be a smooth, ideal, successful post-operative course. Infection in the immune system. The presence of any infection can increase the risk of post-operative infection. So we want to try to make sure that the child is free of infection. Excellent oral hygiene has to be stressed. Many infections originate in the mouth through teeth, through dental decay, gum disease. Many times that can seed bacteria into the blood and cause systemic infection. So really good oral hygiene is a key. And we want to evaluate that. Teach that, promote that, encourage that, really stress that. Some infections can be really subtle and hard to detect. So one of the things that the RBSK nurse can do is kind of promote surveillance, looking at the child before surgery, and looking for signs of something that might be subtle, like a localized skin infection that maybe the child doesn't complain of. Maybe the parents kind of overlooked, they've seen it for a long time. But if there's an infectious process happening locally, we want to try to treat that. We want to try to get that resolved before the child is taken in the operating room. So optimally, a child having surgery will be infection-free. No infection, nothing to increase the risk of a post-operative infection that could potentially be life-threatening for the child. So we want to be very vigilant with preventing infection and observing, determining, seeing infection, discovering infection if it exists. Psychological. This has more of an effect than we sometimes give credit to. We always think of the numbers, we always think of blood pressure, hemoglobin values, potassium, all the lab values like that. But psychological, child's psychological state can have a major effect on how they do in surgery, when they're getting anesthesia, how they do after surgery, how they recover. Basically, we know that the stress response, the more stressed the child is before surgery, the more stressed the child is after surgery, the more difficult it is for them to heal. The stress response will make it more, the stress response results in vasoconstriction. The vessels constrict with stress response. It's going to be more difficult for the heart to pump blood. It's going to be, the heart's going to have a greater workload with the stress response. So if we can do something to prepare the child before surgery, to minimize the stress response before surgery and after surgery, now the child are best prepared for what they're going to experience after surgery, we can help decrease that stress response and again, help promote a good, smooth, ideal post-op recovery. So giving verbal information that can that we can get from the child nonverbal information. We can, with an older child, we can find out about their previous hospitalization and clinic experiences. Did they have horrible experience if they were hospitalized before, or was it relatively smooth? What worked for them? What helped them to make the hospitalization experience or the clinical experience more tolerable, kept them more calm, helped minimize the stress? We can learn from their past if it's an older child that's had previous experiences. And the parents can give us this data too. So the parents, we always have to recognize the parents are the experts. Parents are the experts. They can give us this information and we can use that. And basically, as summary, as a summary point, the child with severe unmitigated anxiety is more likely to have a more difficult hospitalization. And we know that from research and from experience. Um, and one example is fear and anxiety. The child's very anxious. To just begin anesthesia before a procedure can make anesthesia induction, the onset of anesthesia, effective onset of anesthesia, more challenging. And um, so anxiety has effect right from the beginning of surgery and definitely with recovery as well. Possible effects in hospital and later. Several sources said that report that anger, aggression, panic, apathy, anxiety, sleep disturbances, and separation anxiety can all occur during hospitalization. So these are all problems that can occur, behavioral problems, and psychological issues that occur during a child's hospitalization. These experiences that they experience this during their hospitalization, that can persist and continue after the hospital discharge. So if a child has these problems in the hospital with their ICU experience, if their experience on the recovery floor, that can often continue after they're discharged. So the best possible preparation we had before, and the most trained, the most equipped the parents are to help deal with that, to help minimize panic, decrease anxiety, minimize separation anxiety. What we can do is, what hospital nurses can do to decrease separation anxiety is going to help with the long-term recovery, the hospitalization experience, and the subsequent long-term recovery that continues at home. Helpful nursing interventions. Interventions will have to be based on the child's age and cognitive level. So if we're doing with a newborn, an infant, there's a much different approach than if a 2-year-old, 4-year-old, 6-year-old, 8-year-old, older child, school-age child, we can do different things. But one of the things that works well with a lot of younger children is that they can bring things from their home to the hospital setting. So we can talk to parents and say, what's your daughter's, what's your son's favorite toy? What do they like to have in the crib with them? What do they like to go to bed with? Do they have a favorite blanket, a stuffed animal? What do they like to see? What do they like to be with at home? And can they bring that to the hospital? And usually that's not a problem. We might have to launder it, clean it up. We're always concerned about bringing bacteria, microorganisms to the hospital, but usually that's going to be acceptable, and we can have it clean. We can minimize the chance that that's going to bring anything in the hospital setting that could be dangerous infection-wise. So here's a picture of a maybe 3-4-year-old boy with a teddy bear, and he doesn't look happy, but he's probably happier than he would be. He's probably happier than he would be without that teddy bear. So he's probably happier with that, and he has that. It looks like he's pretty far along with recovery, and that's something that works well. I think with my children, my son had a blanket that he loved, that he had to go every place with. And if he had to have a cardiac surgery, had to have heart surgery, we'd like to see him have that blanket. And we think that would help him cope with the stress and anxiety that he'd experience after the surgery. One person here, Jean Johnson, is a researcher, nurse researcher, and she did a number of studies with stress, with children, with hospitalization procedures, with surgery. And one of the things that she found is that if a child can be exposed to what what they'll hear, what they'll smell, what they'll see, all their sensory experiences, maybe what they'll see after during the procedure or in the ICU. Um, and if they can see that before, that will let them tolerate and be more comfortable with those experiences. So the noise of the ICU, the monitors, the alarms, maybe the sound that you have with the ventilator, um, all the activity in the ICU, if somehow they can be experience or get some kind of exposure to that. Maybe it's even like a video or something that has those things. But if they're seeing it for a second time, and if they've seen it before, seen, heard, smelled it before surgery, they're more apt to tolerate it more easily, more readily, and be less stressful than if the first time they encountered it is when they're in surgery. If that's the first time they ever hear those sounds and smells and all that activity, that's going to be more stressful. So if they can be exposed to some of that sensory experience before surgery, that can help, in a sense, desensitize them to what they'll experience after surgery. A lot of children with congenital heart disease will have procedures, but they're also likely to maybe need further procedures. So sometimes things will be staged. Sometimes there'll be an early stage repair. Maybe later in life, a child will need another cardiac procedure, another cardiac surgery. So it's not just, for a lot of children, it's not just a one-time thing. It's not just a one-time thing. It's that they're going to be exposed to it again. And we want their hospital experience to be as comfortable as possible. And so that they can, if they have to repeat procedure, if they have to go back to another type of surgery, another hospitalization, they're going to tolerate that better. They won't be totally fearful. They'll be somewhat more comfortable. So we want to make that experience, the first experience, be as good as possible, as minimize the amount of stress as much as possible. So they're going to be ready. They're going to be able to tolerate future experiences if they're needed. The RBSK nurse can identify families and children that may need extra support. So children have had very difficult experience with previous hospitalizations, previous surgeries. The RBSK nurse can help provide more services before surgery and let the hospital institution know that this child is at high risk for more psychological issues in their recovery, in the ICU, in the postoperative experience on the floor as well. For postoperative care, so principle of postoperative care is that really we want the recovery of a child, we want to think of the recovery of a child to begin early, begin maybe in the recovery room, post-anesthesia, recovery unit if that's used, or in the ICU if they transfer immediately to the intensive care unit. But really we want to start thinking in terms of recovery, in a sense, recovery and rehabilitation right away. We don't want to neglect anything. Our greatest concern right there is their survival, but we're still not neglecting concern about recovery and rehabilitation. So the recovery continues in the hospital, and after the transfer to the ICU, when they're transferred to the regular floor, regular ward, recovery continues, but it doesn't end when the child leaves the hospital. The child is still in the stage of recovery. They're not back to their baseline. They're not back to where we want them to be after their surgical correction, after the procedure. So they're still recovering. Recovery will last a long time. So recovery is a long-term process. It may start in the ICU, continue on the floor, but it definitely continues once the child gets home. And we want them to have a steady, long, progressive, effective recovery. So recovery is a long-term process. Another general postoperative principle is that at least after a child becomes more stable, when a child stable in the ICU, when they're progressing, especially after they get on the floor and discharged to home, that activity is almost always good. Um, a reasonable level of activity, I should qualify this, a reasonable level of activity is almost good. And inactivity or excessive inactivity is almost always bad. So I said there's a few exceptions. We don't want the child to be so active at home that they're exhausted, that they're fatigued. Um, that's not good. That's not good. If they're exhausted and fatigued, they're apt to have more severe pain, more severe pain. They're more apt to be less mobile. But we want them to be active enough, as active as realistically possible without getting to the point of fatigue or exhaustion. Inactivity is almost always bad. A child that's inactive and basically um, you're just lying, not being active, not maybe lying flat. Lying flat increases the risk for respiratory complications in general, but increases the risk of blood clotting, poor circulation, et cetera. It's all those kind of complications. So we want to make sure the child is as active as realistically possible after discharge. And we want the parents to know that a major part of recovery is gradually increasing activity and gradually improved activity tolerance. And that's a steady, ongoing, progressive part of recovery. So, and severe inactivity or great total inactivity is almost always bad. It prolongs recovery and it might also increase the risk of complications. Here, talking about the ICU experience and some of the things people will see in the ICU. So this is a poor child, or hopefully not a poor child, because he or she is going to do well, recover, but going through a pretty difficult experience right here. So sometimes in the ICU, you see a small child like this, you see so many tubes, and you kind of wonder, you're looking and where's the baby in this picture? But you can see the baby. You can see the face, you can see the mouth, you can see the arms, so you can see the baby. But there's an awful lot of tubes here, awful lot of tubes. There's a monitoring wire, cardiac monitoring wires, the leads here for cardiac monitoring. Here's the sternal incision right down the middle of the chest that allows the surgeon to gain access to the heart. Now it's dressed, the dressing's in place. The incision's been closed, the sternum's been closed, but it's dressed. Here's mediastinal tubes. These are tubes that are put around the heart, but they drain from beneath the surgical incision. So here's tubes. Child maybe has a catheter or tube draining urine, IV access. They might have a chest tube on the side. So just many things that the child has in the immediate postoperative period when they're in the ICU. Some children with minor cardiac experience, how long do they spend in the ICU? It really depends. ICU experience duration. Some children with mild cardiac procedures may only spend a day in the ICU, or maybe not even any time at all in the ICU. But that's generally with very minor procedures. However, most children with cardiac surgery, especially with open heart cardiac surgery and cardiac surgeries that require cardiopulmonary bypass, when the blood doesn't circulate through the heart, when the blood circulates through the machine, and when the blood is oxygenated in the machine. So cardiopulmonary bypass when the lungs and the heart is bypassed, circulation bypasses it, is oxygenated outside of the body. Most of those children require at least 2 days in the ICU, probably more, often more, depending on the severity of the surgery. Complex surgeries, and with children with postoperative complications, if they have very difficult surgeries and if they have problems afterwards, they might have to be in the ICU for quite a few days and even weeks. So we have to be, when we prepare parents before surgery, we have to be realistic and say, with our knowledge, we should say most children with the surgery will stay, we say 3 or 4 days in the ICU. Let's say a particular congenital heart repair, 3 or 4 days in the ICU. But let the parents know that sometimes it may be longer than that. And that doesn't mean that the child's going to die, that the child's having a horrible course, but sometimes it's going to take a longer period of time for that. So we don't want to tell the parents like it's going to be just this long. We don't want to give them any guarantee because we can't give them any guarantee. but we can say what typical is, but also let them know that sometimes that stays can be longer because the surgery was more difficult than anticipated, or there were some complications after surgery. Here, with ventilators, some of the things that children experience, almost all children will have an endotracheal tube in place. Usually it can be put in the nose or it can be put in the mouth, through the mouth, but it's a tube that goes down. I should put a tube that goes down into the trachea, and that's used during surgery. The child will be on a ventilator. Here's a ventilator in the background, you can hardly see. It's a small child that's being ventilated. Here you don't see the ventilator, but you see the endotracheal tube. And then the endotracheal tube is going into the mouth, and then down the mouth into the trachea. And that's giving the surgeon, the anesthesiologist, nurses, a secure airway. So we have an airway that is protected. It's a secure airway, and we can deliver oxygen through that. We can deliver air ventilation through that. We can remove secretions by putting a tube with suctioning down that tube to remove secretions when there's too many secretions. But that's kind of a universal in surgery. Most children with real simple procedures, they might even have that tube taken out. They might be extubated, have this tube taken out in surgery, and before they leave the operating room, sometimes in the recovery room, sometimes when they get back to the ICU. But for most surgeries, a child will be on the ventilator, be on the breathing machine, getting supplemental oxygen, at least overnight. For more basic surgeries, maybe the next day, after having hopefully a restful night and some time to recover, they might have the tube removed. For more complicated surgeries, it's going to be in for a number of days. So we can give the parents an idea how long their child will be on a ventilator. But again, we have to let them know that it could be, most commonly it's this period of time, 1 day, 2 days, 3 days, whatever for that particular procedure, but it can be longer than that. And we want them to know that there is a potential for it to be longer than that, and not to have them be overly anxious if it ends up being longer than that. Here's a ventilator. So some children will be extubated the day after surgery. Some children longer than that, many days, sometimes even weeks. If there's serious lung complications, or if the child went in with serious lung problems before surgery, and it's expected that it's going to be a longer recovery, it could be many days, even weeks potentially. One of the things with mechanical ventilation, though, is that there can be complications. If a child's on a very high percentage of oxygen for a long time, that can be actually damaging to the lungs. So high concentration of oxygen can be damaging to the lungs. If we have to use very high pressure, ventilatory pressure, if we have to deliver the air through the endotracheal tube using the ventilator at very high pressure, then that can also cause damage to the lungs too. And that can be a setback for the child. In this picture on top, the infant or the baby is being intubated. The doctor, the anesthesiologist, is using the laryngoscope and looking at the larynx and getting ready to put a tube to ventilate the child. So ventilation, when we extubate the child, that's kind of a critical moment. That's a moment that, we want a successful extubation, that the tube can be taken out and the child will be able to breathe on their own without being on the ventilator and not have to get the tube put back. So we want to remove the tube. We want to have the tube removed as soon as possible, but we don't want to have it removed too early and require the tube to be put back on the child, for the child to be what we call reintubated, for the tube to be put back again, because that can be a setback. So extubate as soon as possible, but we try to avoid doing it too early. Supplemental oxygen, pretty much all children will get supplemental oxygen during surgery and for much of the time, if not all of their ICU stay. So in most cases, we're giving oxygen. We want to maintain oxygen levels. There are some exceptions where we don't want the oxygen level to get too high. So in some cases with some congenital heart defects, where we want to keep the ductus arteriosus open, we don't want the oxygen concentration to be too high because higher oxygen will tend to close it. But that's pretty much an exception. In most cases, we want the child to have adequate oxygen. We're giving them supplemental oxygen from different routes. And usually a child, when they leave the ICU, they may still be on oxygen, but usually by the time they leave the hospital, by the time they go home, they probably won't be on oxygen anymore. Home oxygen is a possibility, but usually the child will be weaned and be safe and be fully recovered enough that they don't need oxygen after they're discharged from home. So we want to give only as much oxygen as needed. I have here at the bottom, long-term oxygen can have side effects. So oxygen that can also be toxic effects, damaging effects to the lung with too high concentrations of oxygen for a long period of time. Here's ways of getting oxygen through the ventilator, through the endotracheal tube. When a child's intubated, we can deliver close to 100% oxygen through the machine. We can deliver a certain percentage of oxygen up to close to 100%. We try to avoid that high concentration, but if it's needed, we can give close to 100%. There's also oxygen mask that can be put on, and some children tolerate this better than others. Some feel real claustrophobic. They don't like the mask put in place. Something that's more comfortable, and when we don't have to deliver quite as high concentration of oxygen, is what we call nasal cannula or nasal prongs. This goes into the nose, into the nostril, but not deep into the nostril. This is another way of giving oxygen. This allows a child to make sound. An older child can speak. Older child, if they're taking food, can eat and still be on nasal cannula and still get oxygen. You can't eat, and it's difficult to speak or understand someone with oxygen mask, but not with the nasal cannula. A child can eat, a child can speak, and be understandable with the nasal cannula in the nostrils. And here's the last one on the right, lower, right here. This one is CPAP or BiPAP. This is where a child's breathing on their own, but they're getting extra pressure to make their breathing easier. So they don't have to have a tube down to their trachea, but they're getting extra pressure, CPAP or BiPAP, and that can be kind of a bridge as they recover. And then they can go from CPAP to BiPAP to maybe just nasal cannula and then no oxygen. So this is probably, this CPAP, BiPAP, this is short of being ventilated, is giving them the most respiratory support. But again, it's better tolerated than being ventilated. Incisions and wounds give you a little more idea of what to expect when you see children at home. Most heart surgeries, most major heart surgeries, we cover a mid-sternal incision. So just down the middle of the sternum, middle of the breastbone, and you can see in this picture, so there's an initial incision, they're making the cut, then they get to the bone, the sternum, that bone is cut in half, the sternum is cut in half, the skin is pulled away, and in here, there's something called retractors. And this spreads the breastbone, spreads the sternum apart, and let the surgeon get access to the heart. So it's open the chest, and now the surgeon has access to the heart. So that's a sternotomy or cutting into the sternum. And when the surgery is over, it's going to be closed. It's going to be closed. This picture here is a picture of a sternal incision that there were problems. There was a wound that didn't heal. There was probably infection, a non-healing sternal wound, and now it's healing. So there's a large wound here. This you don't see that often, but it's a possibility. It's a possibility that you see this large sternal wound that has to heal much more gradually. So that's not what we like to see, but there's some chance of a wound infection at the sternum or a wound that doesn't heal and has to be opened and heal from the bottom up. So much slower healing than we'd like to see. One of the interesting things with adults will have bypass surgery with adults. They'll have the incision on the chest, And they'll also have incision on the legs where they get the graft for the coronary artery bypass graft. But the interesting thing is they usually complain of more pain at the legs than they complain at the chest. The chest is less painful than the legs. So even though it looks pretty horrible, it's probably not as painful as you'd expect from looking at it with a sternal incision. Here, incisions and wounds. In the heart catheterization lab, so if it's not a surgical procedure, but if it's a heart catheterization lab, the cardiologist needs access to a large blood vessel, a blood vessel that's large enough to thread a tube through the blood vessel to reach the heart. And that can be used for a diagnostic procedure to assess the heart function, or it can also be used for a therapeutic procedure to open up a valve, open up a narrowed valve or something. And it can be done. And often, if a heart cath procedure can be done and have the same benefit as surgery, it's preferable. It's a quicker recovery, less dangerous overall than surgery, and less time under anesthesia than during surgery. So here I've got a picture of the catheter being threaded here through the site. Here's cardiac catheterization, and it's being threaded through the groin here, femoral artery, or it could be through a femoral vein, depending what part of the heart wants to be reached. You reach a femoral artery, thread it up to the heart, and here it can be blockage in the coronary artery. It can be a dye study, but with that catheter that's being threaded to the heart, it can give a very good picture of what's happening in the heart and problems with the heart, and also it can be used for treating certain problems with the heart. So with this, there'll be a puncture site. Usually that heals pretty well, but sometimes there's bleeding around the puncture site, and as we're taking care of the child in the hospital, we're looking for hematoma or swelling at the puncture site or bleeding. Because it's a large vessel, there's greater chance of bleeding, particularly if it's an artery that's being punctured. So we want to watch for that. Usually by the time you see the child at home, this should be healed, but check the site to make sure it looks good, that there's no signs of infection, there's no signs of a hematoma or a bulging swelling at the site. It's still good to check that site. Vascular lines, children will always have to have IV access. This is a catheter. This is a catheter that goes in the chest. And this we call the triple lumen catheter. As a nurse working in the ICU in the past, I love these because it's so nice to have 3 different parallel lumens. So you could give one drug that's not compatible with another drug, with blood products. There's one for monitoring. You really love to see these 3 lumens because you often needed all that access. You needed all that access to do what you have to do in intensive care, measuring central venous pressures, giving all the blood products, all the drugs, all the fluids, everything. The triple lumen catheter is wonderful. This shows a peripheral IV. This is an IV in the hand, the back of the hand. So we call this a peripheral line. So this is a shorter line that doesn't go very far. The central venous line goes through a large vein and it goes towards the heart or maybe even up to the heart. So it's a much longer line. But the child will have IV lines. Those will generally be taken out, might be taken out in the ICU, probably taken out by the floor. By the time of discharge, they'll probably be gone. But you'd want to just look at the sites where they were in before and look at the child at home to make sure those sites are healing the way you expect them to be. And they should, so look at previous old IV sites, IV access sites to make sure that they're healing. Vascular lines, more complex surgery, involves an arterial line, usually arterial line. So that's a line going right in the artery, It's a good line for monitoring atrial blood pressure. That should be arterial blood pressure. Arterial blood pressure and obtaining blood samples. If we need to get arterial blood gases, instead of sticking the child, doing a deep stick in an artery, getting a sample of blood, arterial blood gas, we have a line, we can draw it right from there. And we can also continuously monitor arterial blood pressure. So in the ICU, we'd see a waveform, and we'd know if the child's blood pressure is falling quickly or rising quickly, and we can do something about it. So we have a continuous readout of what the arterial blood pressure is. which is important in intensive care because we know children, things can change really fast in the ICU, and we want to be able to respond to those changes really quick. In this case, the child would never be discharged, probably have the arterial line taken out before they leave the ICU. They probably wouldn't have it on the floor, and for sure would not have it going home. But still, we want to look at that site. Often the site's going to be in the radial artery, but there's other sites that can be used for having an arterial line for monitoring. So we want to look at those sites. Pleural chest tubes. Pleural chest tubes are tubes that are put into the lung through the chest wall, and it's put in the interpleural space. And that's a space that lies between the chest wall and the lung. That's normally a very small space, almost no space at all. But in cardiac surgery, when the chest is open up, it allows air to get in the chest, the lungs collapse, and we want the lungs to re-expand when the surgery is over. So we put the chest tubes in, the surgeon will put chest tubes in, and that will drain blood and drain air from that interpleural space. And when we remove that air, we remove that blood or other drainage from the interface, the lungs can fully expand the way they normally expand. Otherwise, if there's blood or air that's trapped in there, it compresses the lungs. And the lungs can't fully expand. So that's a tube that's put through the chest wall in the space between the ribs, and it drains blood and fluid or air from the space between the chest wall and the lungs themselves. Here's a close-up side of a tube with a dressing. It's sutured in, there's stitches to keep it in place. Chest tubes are really, again, removing air and fluid, usually removed a few days after surgery. Usually they remove a few days after surgery, and the pleural membrane or the covering can heal itself, and the child doesn't need the chest tubes anymore. So usually it doesn't take too long. Those are usually removed a few days after surgery. Often they're removed before the child leaves the ICU and goes to the floor. And almost never would you see a child, I should say almost never would you see a child discharged with any kind of chest tube in, unless there's some particular complications. Usually you'll not see those when the child's at home. Mediastinal tubes, these are tubes that are put on both sides of the heart, maybe both sides of the heart, the space between the heart and between the lungs. So here we see next to the heart, between the lungs, on both sides of the heart. But basically these drain bloody fluid drainage from surgery from that space. So it allows bloody drainage that's around the heart, surrounding the heart, to be removed. And that allows the heart to fill as normal during the diastole. If there's bloody fluid compressing around the heart's going to be compressed, and the heart's not going to be able to fully expand. So the heart's not able to fill during the diastole because that fluid is compressing the heart. So we want those tubes to be in to allow the heart to fully expand, normal cardiac function, normal cardiac output. Those are kept in, typically removed as the drainage decreases, maybe 1 day, 2 days, 3 days after surgery. As the bloody drainage decreases, the child can tolerate those tubes being removed, and the heart will have normal function. So this shows a collection device for pleural chest tube. This shows a similar collection device for the mediastinal tubes, the tubes that are next to the heart, draining fluid from around the heart. So here's mediastinal tubes again, and here's another picture of mediastinal tubes. Urine Foley catheter, urine or Foley catheter. This is a catheter that's put through the urethral orifice, into the bladder. There's a balloon at the end, and the balloon is inflated to keep it in the bladder. Often done when the child's under anesthesia. Generally, we want to watch urine volumes real closely. So initially, the urine volumes we measure real closely. We make sure the fluid balance is adequate, that the heart's functioning the way it should, kidney function is adequate. If the heart's not working well, there'll be less urine output, kidneys won't work well. So we want to keep close tabs, a close watch on how much urine the child's making in the ICU experience, in recovery. And typically the catheter is removed as soon as the child's stable. If the catheter is left in place, the chance of a urinary tract infection just gets greater and greater and greater with the longer the catheter's in. And usually as soon as the child's stable, we can start measuring output by weighing dry diapers, wet diapers, figure out the difference, and then determine what urine output is based on the difference between weight. But in the more intensive care state, we want to watch urine output very closely because that can be a real sign that the child's having kidney problems or there's poor cardiac output and the kidneys aren't getting the blood flow that they should be or that they don't have enough fluid. What you might see when the child gets home, usually all these lines and drains are discharged by the time the child are removed before the child leaves the hospital. But it's likely you'll see evidence, and you should monitor for certain things when you see the child at home, the former sites where these lines and drains used to be. Here's chest tube sites. These are pretty fresh. These are just 2 days, 2 days after surgery. It's removed. There's still some, these been sewn shut, sutured shut, but so you can see where it was. This should gradually become less and less apparent, but you'll still be able to see the site when the child gets home. Whether the sutures, the stitches, the sutures are in or not in, might vary, but you'll probably see something, either sutures or pieces of tape called steri-strips closing that. These are tube sites that have problems. These are tube sites that didn't heal, they've become infected. You see the redness around here. This isn't a good sign when you see all this redness. And when you see this running redness, so if you see something like this with a former tube site, let the doctor know, make sure that it's followed up because this could be a sign of infection, as actually a pretty likely sign of infection. So you'd like to see tube sets are healing, that are getting better, that are gradually closing. But when it's like this, it's a good chance that it's infected. Central lines, central IV lines, we call it central line because it goes in large vessel. Here's some signs of infection at the site. Here's some signs of infection after it's been removed. This is healthy, what you'd like to see it look at. Here's some inflammation. This is worse, number 2. And this is signs, that's a sign. This is a sign that there's some infection at the site. So lots of times the central lines can become infected. Often doctors like to get them removed as soon as possible because it can be a source of infection. But we want to look, when we see the child at home, we want to look at those sites, see what they look like, and hopefully we won't see much. It'll be a nice small site, healed, not a lot of redness, very little redness around it. And that's what we'd like to see. Sternal incisions, here's a well-healed incision. This child's still in the hospital, but it's closed. There's no drainage, there's no separation. Here's also a nicely healed incision. Again, closed, no drainage, no separation. This is good. Now here's an incision, a sternal incision that's been closed, but things don't look normal. You see more redness around here. This could be possibly infected, and inflammation of the sternum would be called a sternitis. So this could be inflamed, possible sternitis. If you saw something like this, and especially if it's undocumented new environment, let the doctor know, let the pediatrician know, because that might require further follow-up. That could be something that's not healing or infected. So scars, one of the things children will have, throughout their life, they'll still have a scar. They'll still have a scar, regardless when they had the surgery. They'll still have the scar that's visible. It should be pretty clean. It should be pretty minimal. But that's the thing we have to consider. Children, especially a little bit older children, younger children could take things in stride pretty well. But older children, especially self-conscious, maybe pre-adolescent, adolescent children, are going to be really self-conscious. They don't want to be seen with incision on their chest. They don't want to be in a bathing suit. Young girl, boy, they don't want that incision to be visible. And one of the interesting things, there's a camp in Minnesota, in my state. I've been there once to visit it. And it's for children with congenital heart disease, children with heart disease. And in that case, in that place, you stand out if you don't have an old incision. If you don't have an old incision, you look kind of different. So these kids can really enjoy being with each other because no one's embarrassed about having a chest incision. They're comfortable. And here's some boys, but the same thing with girls too. Girls wearing bathing suit with incision would show. they feel really comfortable around other girls with the same state. Late appearing complications, respiratory complications. Anytime a child is active, there can be late complications. Pneumonia can develop. If they have problems, if they have cardiac complications, cardiac conditions that are totally resolved, and they still have greater pulmonary blood flow, greater blood flow to the lung, that can increase the risk of infection too. So you want a child to be active, to be sitting up, to deep breathe, to lessen the chance of later acquired pneumonia or lung infection. Psychological, getting towards the end here, we can have concerns, overly dependent on others. After surgery, a child can be very dependent. A child can become angry and irritable. Sometimes they're going to be actually mad at their parents, like, why did you make me go through this? This was a horrible experience in the hospital. Why did you make me do this? It's your fault. Why did you make me so? They can be actually angry at their parents, irritable. Sometimes parents can be overly protective. Parents can be too protective, and that discourages the normal progression level of activity that we need to see as a child has recovery. So parents can be overly protective as well. Summary, so you as an RBSK nurse, visiting children at home before and after surgery can have a major impact on the well-being of these children. Children will do better in surgery, in the ICU, in the on the floor after surgery, and much better at home because of your role, the things you do, visiting children before surgery, working with families before surgery, and working with families after surgery. So thank you and good luck in your very important, very vital, very commendable work. Thank you.